Okay, so imagine you've got this high-performance engine, right? And it's perfectly calibrated to regulate the pressure across this massively complex network of pipes. Now think about what happens if that engine's accelerator just gets permanently jammed all the way down. And the brakes? Well, the brakes just completely vanish. You can picture it, right? Pressure builds, the whole system strains, and eventually the pipes are going to start giving way. Well, in the human body, we have a meticulously balanced sodium-retaining engine that does exactly this. It maintains our blood pressure and our fluid levels. But when this system loses its off switch, the resulting cascade of mechanical failures is absolutely fascinating and honestly incredibly destructive.
Welcome to this explainer. Today we are taking a first principles look at mineralocorticoid excess. We're going to break down exactly how this critical physiologic failure happens, starting from the microscopic genetic glitches that spark the fire, all the way down to the devastating tissue toxicity that follows. And finally, we'll look at the diagnostic logic of how we can scientifically track down this broken engine.
All right, let's dive into this. Chapter 1, the runaway sodium engine. To really understand the failure, we have to look at the whole system. You know, the endocrine system is essentially the body's integrated network of chemical regulatory signals. If you notice those adrenal glands sitting right there on top of the kidneys, they are the absolute command centers for our fluid and salt balance. Normally, intercellular communication here is, well, it's like a symphony. You've got signals acting locally, which we call paracrine, some acting on themselves called autocrine, and others traveling long distances through the bloodstream, which is your true endocrine signaling. Most of the time, this all works in perfect harmony.
But here is exactly where the machinery breaks down. See, in a healthy system, when you have enough hormone floating around, a feedback loop tells the gland, okay, we're good, shut off. It's an elegant, self-regulating thermostat. But when benign tumors like adrenal adenomas develop, they essentially delete that off switch entirely. They start producing excess hormones due to defective feedback regulation. The gland literally stops listening to the body saying, we have enough. It just keeps pumping and pumping.
Which brings us to Chapter 2, Mineralocorticoid Excess Explained.
So the most common cause of this whole runaway process is primary hyperaldosteronism. This glitch is characterized by the autonomous, totally uncontrolled secretion of a hormone called aldosterone, specifically originating from a tiny layer in the adrenal glands known as the zona glomerulosa. And this fundamentally alters the body's baseline chemistry. Because the adrenals are just indiscriminately dumping aldosterone into the blood, the body actually tries to compensate by severely suppressing its plasma renin levels.
Now, this isn't exactly a new concept, even though our molecular understanding of it has absolutely exploded recently. We can actually trace this back to 1955. That's when J.W. Conn first described this exact syndrome in a patient who presented with hypertension right alongside an aldosterone-producing adenoma. Ever since then, Conn syndrome has been the classic textbook example of this runaway engine. But, as you'll see, the mechanics behind why it actually happens go so much deeper. Chapter 3, Glitches in the Code. Let's look at how these mechanical failures originate at the cellular level. Breaking down the root causes, or the etiology, the two main subtypes are bilateral idiopathic hyperplasia, which accounts for about 60% of cases, and aldosterone-producing adenomas, or APAs, making up roughly 30%. Now, what's really interesting about this is that compared with bilateral adrenal hyperplasia, patients with an APA tend to have far more severe disease. We're talking significantly higher hypertension, lower potassium, and just massive spikes in aldosterone. So why is the APA so aggressive? Well, it's because the code inside the cell is physically broken by somatic mutations. Take the KCNJ5 mutation, for instance. It affects a potassium channel and gets identified as the culprit in up to 40% of these adenomas. When these ion channels mutate, it directly results in the upregulation of a specific enzyme called CYP11B2, and that forces continuous autonomous aldosterone synthesis. The cell is literally hardwired to never ever stop producing. And it's not just sporadic. This can actually be inherited, which we call familial primary aldosteronism. Take type 1, for example. Here, an actual genetic crossover occurs between the CYP11B1 and CYP11B2 genes. This creates a chimeric gene where aldosterone production is suddenly driven by ACTH, which is a completely different signaling pathway. The result? Severe, incredibly treatment-resistant hypertension appearing in childhood or early youth. It's just a devastating structural glitch right from birth.
Moving on to Chapter 4, downstream carnage. What happens when all this excess aldosterone hits the body's tissues?
To really grasp the downstream effect, we have to zoom in on the receptors.
We can use rare conditions like Little's syndrome as a perfect model here. In Little's, you have mutant ENaC subunits, ENaC being the epithelial sodium channel. That mutation keeps the membrane channel locked in this open conformation for way longer than normal, drastically enhancing mineralocorticoid action. So even though the primary defect is different, it perfectly demonstrates what excess mineralocorticoid activity does. It locks the sodium channels wide open. The body just obsessively hoards sodium and violently dumps potassium.
So the absolutely crucial point here is that this massive sodium retention leads directly to a very specific clinical presentation. We start seeing patients with profoundly resistant hypertension. Blood pressure is often hitting staggering numbers, like 184/112. At the exact same time, because those open ENaC channels are basically trading potassium for sodium, we see severe hypokalemia, or potassium wasting. In fact, this huge potassium drop shows up in up to 28% of hypertensive individuals with this condition. You'll also see polyuria and nocturia as the poor kidneys just struggle under all that pressure.
But honestly, here is the most terrifying part. The danger isn't just the mechanical pressure on the pipes, it is direct aldosterone tissue toxicity. Excess aldosterone literally ravages the cardiovascular system. It leads directly to atrial fibrillation, coronary artery disease, heart failure, left ventricular hypertrophy, and stroke. Plus, it severely damages the patient's quality of life and is heavily linked to profound anxiety, depression, and stress. The hormone itself, when there's too much of it, is just straight up toxic to the heart.
Which brings us to our final chapter, Chapter 5, the diagnostic logic.
Tracking down this integrated system failure really requires clinicians to act like detectives. Step 1. You actually have to suspect it. This is usually triggered by a patient under 35 with low potassium or someone with truly resistant hypertension. Step 2 is casting the initial biochemical net, measuring the aldosterone-to-renin ratio, or ARR. Because the engine is running completely autonomously, you're going to see sky-high aldosterone right alongside severely suppressed renin. But you don't stop there. Step 3 is actively pushing the system to see if it responds at all.
We do this through confirmatory suppression testing. That means using tests like salt loading, fludrocortisone suppression, or captopril suppression. The logic here is beautifully simple. If we flood the body with salt or synthetic mineralocorticoids, a normal adrenal gland will hit the brakes and stop making aldosterone. But if the patient has Conn syndrome or bilateral hyperplasia, those brakes are completely gone. The aldosterone levels will just fail to suppress, and boom, the diagnosis is confirmed. Once it's confirmed, clinicians often rely on adrenal venous sampling, or AVS. That's a super crucial procedure where they sample blood directly from the adrenal veins to pinpoint exactly which side is misfiring.
Now, once it's confirmed and localized, managing the system is an incredibly delicate balancing act. Clinicians often try to manipulate this pathway with drugs like MRAs, or mineralocorticoid receptor antagonist, to basically block the toxicity. However, manipulating this hormonal axis, especially in patients who might have underlying renal issues, like type 4 renal tubular acidosis, well, it has to be done with incredible precision. Otherwise, you risk wild swings in the totally opposite direction, causing severe hyperkalemia and acidemia. You really have to respect the machinery. So we've seen how a tiny genetic glitch can completely destroy the off switch of the zona glomerulosa, leading to rampant aldosterone production, unyielding hypertension, and just devastating cardiovascular toxicity. But here's the thought I want to leave you with today. The data suggests this specific mineralocorticoid excess occurs in anywhere from 6% to 20% of all adult hypertensive individuals. That makes it the single most common cause of secondary hypertension. So look around. If 1 in 5 people with high blood pressure might actually be suffering from this curable yet highly toxic endocrine malfunction, how many broken engines are just hiding in plain sight waiting to be diagnosed?